Welcome to The Explainer. Today, we're putting you right in the hot seat. We're about to walk through one of the most intense moments in a surgeon's career, the consultant viva exam. In our case, it's a classic surgical emergency, intestinal obstruction. Let's see how a top-tier candidate handles the pressure when every single answer counts. Now, this isn't just some made-up scenario. Our entire case is built around the tough standards of the Saudi Commission for Health Specialties. I'll be your guide here, but you'll also be hearing from two other key players, a really sharp candidate who has to think fast on their feet, and a seasoned examiner who is definitely not looking for simple textbook answers. This is about as real as it gets.
So, what you're about to see isn't just a random Q&A. We're following the exact logical flow of a real clinical case, which is precisely what examiners want to see, a structured, systematic approach. We'll kick off with the opening scenario, work our way through the history and physical exam, and then get into the really high-stakes decisions about management and surgery. This isn't just about passing a test. This is the blueprint for how to handle these cases in the real world.
All right, imagine this. The candidate has just walked into the room. The pressure is on, and the clock is officially ticking. The examiner doesn't waste a second and jumps right in with the opening scenario. Let's tune in and hear what our candidate is up against. Here's the examiner. A 35-year-old man presented to the emergency department with severe upper and central abdominal pain for 2 days, associated with abdominal distension. Okay, so the challenge has been laid out. A young guy with severe belly pain. This could be a whole bunch of things. Pancreatitis, a perforated ulcer, the list is long. So the candidate's first move here is absolutely critical. They've got to show a systematic approach right out of the gate. And a focused history is where you start to unravel this whole thing.
The examiner looks at the candidate and asks, how would you approach him?
And listen to this confident reply from our candidate. I'd start by taking a focused history. First, I'll dig into the details of the abdominal pain. Second, I'll ask about any vomiting, what it's like, how often. Third, I need to know about constipation, specifically if he's not passing any stool or gas. And finally, and this is crucial, I'll get a really thorough past medical and surgical history.
The examiner gives him more information based on those questions. Okay, he's had repeated vomiting and hasn't passed any gas for the last 24 hours. And his surgical history? He had a splenectomy 2 years ago after a car accident. Okay, now this is where it gets really interesting. The candidate just got some huge clues. Repeated vomiting? That points to a blockage somewhere high up. Not passing gas for a full day? That's a massive red flag for a complete obstruction. And a previous major abdominal surgery? The word adhesions should be flashing in their mind right now. The next logical step is the physical exam to see if the signs on the body match the story.
So the examiner pushes forward. What will you do next? And the candidate is ready with a plan. I'll perform a thorough physical examination. I'll start with his vital signs, then a full abdominal exam. I'm looking for distension and scars, checking for hernias, feeling for tenderness, and listening for bowel sounds. I'll finish up with a digital rectal examination. The examiner reports the findings. On examination, he definitely looks uncomfortable. His abdomen is moderately distended, and you can see a clean scar from his previous surgery. There's no tenderness, but the bowel sounds are exaggerated. The rectal exam was empty. All right, you see how the puzzle pieces are clicking into place. You've got the distended belly, the surgical scar, and those classic, high-pitched, exaggerated bowel sounds. That's basically the sound of the intestines fighting against a blockage. So our candidate has done the assessment, and now it's time for action. They need to lay out a clear plan to both stabilize this patient and get the proof they need. The examiner asks the big question, so how are you going to manage this patient? And listen to this textbook answer. My management will have 2 parts, immediate resuscitation and investigation. First, he needs to be hospitalized. I'll make him NPO, which means nothing by mouth, insert a nasal gastric tube to decompress his stomach, and start IV fluids. At the same time, I'll send off for baseline blood work, like a CBC and a renal profile, and order a plain abdominal X-ray. The examiner provides the results. The investigations come back. His plain abdominal X-ray shows a distended small bowel with multiple gas fluid levels. His white blood cell count is 11,000, and his renal profile is a bit elevated. And there it is. That's the smoking gun. The candidate's plan was perfect. The IV fluids are already tackling the dehydration, and that X-ray finding of distended bowel with multiple gas fluid levels, it kind of looks like a stack of coins, is the classic sign. It's practically screaming obstruction. All the clues are pointing in one direction. This is the moment of truth. It's time to make the call. The examiner asks, what is your provisional diagnosis?
The candidate answers clear and direct. My provisional diagnosis is mechanical intestinal obstruction. The examiner probes deeper. And what is the most likely cause in this particular patient? The candidate connects the dots perfectly. Given his history of a previous splenectomy, the most likely cause is postoperative adhesions. And that is a fantastic answer. They've nailed the diagnosis and the cause. Adhesions are basically bands of scar tissue that can form after surgery and kink up the bowel. But remember, this is a consultant exam. They're not done yet. The examiner is now going to shift gears and really test their judgment. It's not just about what's wrong anymore, it's about what to do and, more importantly, when to do it. This is what separates the junior doctors from the consultants. The examiner asks a critical question. What are the indications for emergency surgical intervention in a case like this? The candidate lists off the absolute red flags. The absolute indications for emergency surgery are any signs of ischemia, where the bowel is losing blood supply, or peritonitis. Also, if the patient doesn't get better with conservative management after about 24 hours, or if they have a strangulated hernia, or if imaging shows the cecum is blown up bigger than 13 centimeters, which means it's about to pop. The examiner has one last question. Good. Last one. Since adhesions are the problem here, how can you prevent them in the first place? And the candidate shows they're thinking ahead. Prevention is all about your surgical principles. It comes down to meticulous technique with really careful, gentle tissue handling. It also means minimizing exposure to foreign bodies, like bits of gauze or too much suture material. And finally, using laparoscopy whenever you can has been shown to reduce adhesion formation. And there you have it, just a flawless performance under pressure. The candidate didn't just diagnose and manage the immediate problem, they showed their thinking at a higher level about prevention. And really, that's the key takeaway. Any surgeon can take a patient to the operating room to cut those scar bands. That's called an adhesiolysis. But a truly great surgeon is already thinking about how their actions today will prevent that next case years from now. It just goes to show you, the most important part of any surgery might be how carefully you handle things, knowing that every single touch has consequences.